as I was introduced, I'm a medicine pediatrics physician in my background. I do actually now mainly research. I do one clinical day a week, but most of my time is research, and my research interest is in the translation of evidence into practice and policy, and specifically using implementation science, this new field of implementation science, and implementation science tools to reduce cardiovascular risk disparities, both in the US as well as worldwide. So no relationships disclosed. So my goal today is to give you a review of the evidence for diabetes prevention, and then to use our diabetes prevention intervention, the Lyme study, to really make a case for why implementation science is one of the best ways we have now to try to promote health equity. So I'll first start with a review of the Eastern Caribbean Health Outcomes Research Network, talk about diabetes in the Caribbean and Caribbean descent populations. I'll talk about the evidence for diabetes prevention, the role of implementation science in addressing the no-new gap, and then tie it all together with our Lyme study. So why do we at the Equity Research Innovation Center at Yale work in the Caribbean? And these are four of the primary reasons. So one, it gives us an opportunity to address territorial health disparities. There's a large immigrant population to the U.S. that comes from the Caribbean. The disaggregation of race today is becoming ever more so important. And there's truly an epidemic of NCDs in the region. So this was a paper that was published in 2011 by our principal investigator, Dr. Marcella Nunez-Smith, which really highlighted the true disparities in quality of care in the U.S. territories versus the U.S. mainland. So this was primarily looking at inpatient care. So we actually do not have data yet for outpatient quality of care, but clearly showing a significant increase in the number of additional deaths per 100 for acute myocardial infarction, heart failure, and pneumonia. And unfortunately, Puerto Rico and the U.S. Virgin Islands continue to be understudied populations, with very minimal research actually happening on those islands. But what we also recognize is for us to get a better understanding of what drives those health disparities in those territories, we really need a Caribbean context. And that is why we actually put a lot of emphasis in not only having the U.S. territories of the U.S. Virgin Islands and Puerto Rico in our consortium, but also actual Caribbean islands within the region, which for us are Barbados and Trinidad. So as you see here, the Caribbean individuals are forming a growing proportion of foreign-born blacks in the U.S. And as I mentioned before, in this era of precision medicine, disaggregating race, so understanding how different populations within race and ethnicity can react differently to interventions is really, really important. And we live in an era of significant human, cultural, economic migration. And so the health of our neighbors, whether we like it or not, directly affects our health. And so this is an example of how when the Caribbean nations are experiencing what is truly an epidemic of non-communicable diseases. So proportions of non-communicable diseases that are comparable or higher to what we see in minority populations here, where heart disease, diabetes, and cancer account for greater than 50% of deaths in the Caribbean. So it's in this context that in 2011, the Caribbean community, known as CARICOM, recognized this plight that they were experiencing with non-communicable diseases. And they are actually the people who called the first UN high-level meeting on non-communicable diseases. As you know, the third one just happened very recently in New York with a lot of hubbub. But the first one was actually brought together by the Caribbean community. And it was Sir Trevor Hassell and Sir George Lane who were kind of the critical forces in bringing that together. So it's really in that setting that ECHORN was born. So ECHORN is the Eastern Caribbean Health Outcomes Research Network. It's really a unique collaboration between the islands of Puerto Rico, U.S. Virgin Islands, Trinidad and Tobago, and Barbados, with the goal of addressing non-communicable diseases in the region for the reasons that I outlined previously for why studying the Caribbean is important. So it strengthens capacity for research on NCDs, and it established a first of its kind cohort study, adult cohort study in the region. These are the principal investigators. This is a multi-principal investigator project that is funded by the National Institute of Minority Health and Health Disparities. In 2016, ECHORN received a second grant from NIMHD to now expand its work to what's the Yale-TCC, that long name that we gave, which we call the Yale-TCC. So this allowed us to bring in New York and New Jersey, which, as you know, have very significant proportions of the population who are Caribbean descent, but also to help us focus our research agenda on diabetes and hypertension. This was a call directly from our stakeholder network within ECHORN that these were the two NCDs that were causing the greatest amount of morbidity and mortality. And then most importantly, it allowed us to create an implementation core where we became focused on the translation of evidence into practice and policy. So I am now the Deputy Director of the Yale-TCC, and I lead the implementation core. So in that core, we've decided to first focus on diabetes. And as you see here, except for 2 of the Caribbean islands, all of the other islands have a significantly higher prevalence of diabetes compared to the United States. But as this audience knows very well, even within the United States, we have significant disparities in diabetes prevalence with much higher rates in some of the minority groups. And we also know that the rates of diabetes are only rising and will continue to rise unless there is concerted effort and action towards diabetes prevention. And so that is why both the Pan American Health Organization, which is a subdivision of the WHO, as well as the American Diabetes Association here in the US, have put out some strong recommendations for how we can address diabetes prevention. So PAHO has put out the 7 key action items you see here, of which one of them is primary prevention. And the American Diabetes Association, in actually all the editions of its standards of medical care in diabetes, always has a section on diabetes prevention, which we'll talk a lot about today in terms of the evidence behind it, but recommendations for screening, recommendations for how to screen, and how to treat diabetes prevention. So let's pivot now and talk a little bit about the evidence for prevention. And it all started with this, which we have now all become very familiar with, the 2002 article that came out in the New England Journal of Medicine describing the diabetes prevention program. And this curve, which I still remember my chief resident presenting the article when it first came out, so looking at the difference in the incidence of diabetes in the 3 arms of the study. So the diabetes prevention program had a placebo arm, a lifestyle modification arm, and a metformin arm. And showed clearly that with lifestyle modification, you've got the largest reduction in the cumulative incidence of diabetes. But there's a lot that I want to parse out here today. So one was that the data that was shown for the diabetes prevention program was shown based on diabetes diagnosed by fasting insulin or OGTT. This was before the era of A1C and the use of A1C for diabetes diagnosis. So there was a fair proportion of individuals within that group who actually had an A1C above 6.5%, and which today we may have classified as having diabetes. And could that have skewed the data in some way? So they actually did a post hoc analysis taking out that group of individuals who would have been classified as diabetes. And these are the results from that post hoc analysis. Which shows that, so this is DPP by glucose, and this is the follow-up study from DPP. And if you go here, this is DPP if you use the diagnosis of A1C at greater than 6.5%. And you can see 2 things. So one is that you had a significant reduction in cumulative incidence. This is cases of diabetes per 100 person years. A significant reduction at the higher baseline A1C level. And that'll become even more important when we talk later. But that now metformin and lifestyle were much more close in terms of their effect on the incidence of diabetes than what we had seen previously for the full DPP study using a different criteria for glucose. So I just want you to keep those 2 points in mind. So one, that metformin and lifestyle were similar when we take out those groups that could have had diabetes by A1C, and that the reduction was significantly greater for that group between 6 and 6.4% for baseline A1C. So then let's look at the racial and ethnic breakdown within DPP, which for us studying health disparities is very important. And the DPP really promoted the fact that it had 45% of its population in the study were minority. But for those of us who are interested in what exactly minority means and what those groups mean within that group of minority, you can see that there's actually a very small proportion within groups, right? So 11.7% Black women, 5.7% Black men, Hispanic men 5.6%, and Hispanic women 6.4%. And what we were just talking about before is when we lump these all together, yes, it's going to be 45%. And what does that really mean when we try to do tailored interventions for minority populations? And to give you an example of why this is important, they were not powered to look at effects by race, okay? But they wanted, just curiosity-wise, let's just see what the effect was if we break down the groups into white male, white female, black female, Hispanic male, and Hispanic female. And so this is the group within lifestyle intervention. And you can see that for some reason, the Black females in the study had significantly less weight reduction than the other groups. And the question is why? And what does that mean for us when we're trying to design interventions that are tailored towards this population? For the metformin group, there was no difference. So again, a gap in what we have from DPP that we somehow need to answer when we're trying to target minority groups. And then there was the big DPP outcome study that we were all anxiously awaiting, and which showed that there was still a significantly larger reduction in the cumulative incidence of diabetes in the metformin and the lifestyle arms, but that they had come closer together now, that there was not a significant difference between those two. But what everybody was more interested in was this, which was what is the effect on microvascular complications? And what is the aggregate effect on microvascular complications if you have metformin, lifestyle versus placebo? So what was really interesting was that when you look at the aggregate amount of microvascular complications, taking everybody who developed diabetes, everybody who did not develop diabetes, based on whether they were in the treatment arms or the lifestyle arm, there was no difference. But if we parse that down just a little bit and look at, this is the breakdown by group. So this is men, this is microvascular disease prevalence, placebo, metformin, and lifestyle. Not much of a difference. Women, there is a difference, and this was a statistically significant difference. So when we now try to look at the subgroups within the DPP, you can see that in women, lifestyle did have a significant reduction in microvascular disease prevalence. And this is looking at everybody, diabetes and not diabetes, based on the fact that they were in the lifestyle arm versus in the metformin arm. The other thing to note is that if you did not develop diabetes, you still had a significantly reduced rate of microvascular complications, reduced by 28% compared to if you developed diabetes. So remember, the whole point of metformin and lifestyle was that you don't get diabetes. You delay the onset of diabetes. And this is just proving that when you delay the onset of diabetes, you're not getting microvascular complications, which we kind of knew, but this is proving. And again, what happens when we take out that group that we would have classified as diabetic based on A1C? And you can see that when we take out that group that would have been classified as diabetic by A1C, we now do see a reduction in the aggregate prevalence of microvascular complications in lifestyle versus metformin and placebo. What about cost effectiveness? Well, I think there have been a lot of studies looking at the cost effectiveness of DPP. This is a table from just one of them, and you can see that when we look at cost effectiveness and look at it in a societal perspective, and you look at, this is lifestyle and this is group lifestyle, and you can see that there is a cost associated with it, and then the ratios when we look at them will determine how cost effective that is, and that when you look at metformin, it's actually cost saving. So again, this is now looking at incremental cost effectiveness as a ratio of the changing cost versus the change of quality of adjusted life years. And you can see again, metformin is cost saving, and DPP group lifestyle costs significantly less than the individual. And that's why now with the National Diabetes Prevention Program, everybody's moved to group. So this is a neat slide I got from Dr. Ed Gregg, who's at the CDC and has run a lot of the cost effectiveness data around the diabetes prevention program. So on the y-axis here, you have the 10-year diabetes incidence, and this is A1C. The point of this slide is to show that at the higher A1Cs, you actually have less cost per quality adjusted life. So again, why we should be targeting the highest of the highest risk. So here, 15,000, it goes up to 44, it goes up to 89, and it keeps going. So making the point that this is the group you need to target. And that means that even if we were to parse out that 5.8 to 6.5 and focus on an even narrower group, we would be even more cost effective. This is putting it a different way, looking at incremental cost effectiveness of alternate A1C. So again, the cost per quality of life adjusted years, this is A1C, and this is the incremental difference in cost. And you can see that there's almost a sweet point, right between that 6 and 6.4%, right? Right before it goes back up again in terms of cost, and this way too. So right, you're having higher cost if you're looking at that 5.7, 5.8, you're still having a higher cost per quality adjusted life year than if you were to look at slightly higher A1Cs. You'll see why I'm beating this point down in a minute. Now, what about the translation of DPP to the community? And there have been several systematic reviews that have looked at translation based on different criteria. a lot coming from the implementation science community that's really interested in how people describe the translation of DPP into the community and what we can learn from that. So I kind of looked through some of the big ones, and there's a few take-home points. So one, translation has been done in churches and clinics and community centers. There are actually very few, relatively speaking, that have really targeted and been tailored to racial and ethnic minorities, and only a couple that have actually had a follow-up period beyond 12 months. And that's really critical if you're trying to show that there's a reduction in diabetes incidence. There's no reported diabetes prevention studies in low and middle income countries that have passed 12 months. And there's really, in all of these systematic reviews, a push for us to talk more about adaptation, the process of adaptation, how and why these interventions do or do not work in the community, and for whom does it work, and most importantly, sustainability. And very recent, this came out in the end of 2017, December 2017, doing a systematic review looking at the long-term sustainability of diabetes prevention efforts. And they had three conclusions. So one was the obvious, lifestyle modification and medication successfully reduce diabetes incidence. We've already seen that. And that the medication effect, if you stop it, is short-lived. Well, I think we all kind of expected that. So when you stop the metformin, you kind of lose the added effect that you have for diabetes prevention. And sustaining lifestyle modification is different. If you're able to sustain it, you do great, and you actually prevent diabetes. But the problem is people have a hard time sustaining it. So from this review, these are the gaps that we can kind of gather. So one, there's limited translation studies that are tailored to minority populations. We really don't know what the best way is to adapt existing interventions to minority populations. And what is the optimal A1C to target? And should that A1C be different? How do we sustain lifestyle modification? What is the effect if we add metformin to lifestyle, right? We had two different arms, metformin and lifestyle, but what if we do lifestyle and then metformin? Is there an additive effect? And what is the effect of metformin when we only target the highest risk group within that for diabetes? So before we move on, let's just kind of summarize. So diabetes prevention, I hope I've shown, is effective. The aggregate microvascular complications are lower if you don't develop diabetes, but there's also some data, remember when we took out that group that does have diabetes by A1C, we still show aggregate microvascular reduction just by lifestyle alone. Diabetes prevention is cost effective and in some cases cost saving, and if we target the highest risk individuals, we could be even more cost effective and even more cost saving. And we have a lot of work to do. We need to figure out how to translate prevention to communities and minority groups. And we really have to figure out how do we design effective, sustainable, and scalable interventions.
Question.
Yeah.
So it showed that it's more cost effective to intervene on individuals in that 6.0 to 6.4 group. If you intervene earlier, do you end up with a lower progression to diabetes, or don't have that data to show?
I don't have it in my extra slides. So you're asking, does the rate of progression to diabetes differ based on your baseline A1C?
Right.
And so that I can answer is yes.
Yeah.
And that's probably why in that bar graph that I showed, you saw a larger reduction in the incidence of diabetes when you only looked at that 6 to 6.4%. Right? And that's probably the explanation for.
And the intervention at that lower group doesn't affect the rate of progression that much, or we're not sure.
Yeah, we're not. I don't think it's been parsed out that way. So all we can say here is that you have a larger reduction if you target that group. So how you affect this group in the long run, though, yes, I think that. So implementation science is very well positioned to help us answer these gaps that we've identified. And the question is why? So what is implementation science? So the latest research shows that we really should do something with all this research. And I think that DPP is a perfect example. 2002 and we're now in 2018, and we still don't have effective diabetes prevention interventions for minority populations. Right? So there's this concept of the 17-year odyssey, where we start from when research is funded, and it takes 17 years for less than 20% of research to actually make it to practice. Right? So why is that? And what can we do to stop that, to shorten this 17-year gap? So there are many definitions of implementation science. This is the one that I like, the study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine health care and public health settings. So it's really trying to determine what is your no-do gap? What is the evidence to support how to address that no-do gap? And how do you really understand why the translation of that evidence into practice has not happened? What are your barriers? What are your facilitators? How do you figure out how to develop effective programming to address that no-do gap, but being informed by your local stakeholders and implementers who are actually doing the work? So, traditionally, that's what Martin Eccles said. So it seemed like a good idea at the time. So we used to always have this policy where we would just think we had the best intervention, we would go in with the best intervention, and then it wouldn't work. And the question with implementation science is, one, don't do that. But if you do that, try to figure out exactly why it didn't work. So implementation science really focuses on translation. So we focus on the T3 to T4 level here. It is truly a multidisciplinary discipline. And so this is a slide I borrowed from Dr. Luke Davis, which shows that it's really a kind of amalgamation of the social sciences, the clinical sciences, the population sciences, and the engineering sciences, which all come together at the confluence of implementation science. It really exists along a spectrum, or a continuum. So people know this as knowledge translation. Other people think of it as fitting in with health systems research. It's really a part of quality improvement. It's part of monitoring and evaluation, operations research, impact evaluation. These are all terms which some people can refer to, and usually it's a subset of implementation science that may overlap with these disciplines. But I like this diagram of the continuum where there's operational research, implementation research, and then health systems research, and your research utility actually increases as you go. In implementation science, we are truly focused on behavior, and we're sometimes obsessed with behavior, and how do we change behavior, and what does it mean? We're really thinking about the mechanism. How do we get from a health intervention to a health outcome? And what are all of the factors here in the middle that determine that process and affect that process? So whether it's behavioral factors at the individual level, whether it's environmental factors and contextual determinants. And so we really use an ecological model where we look at, when we develop our conceptual models for our interventions, what are all of the different levels that are at play for us to explain the mechanism that goes from the health intervention to the health outcome. So some of the core principles of implementation science: it tackles real-world practice, the no-do gaps. It's multidisciplinary. It engages stakeholders at multiple levels, strives to understand and systematically describe behavior and mechanism, and takes into account context. So what I'll try to do is show you how we've applied some of these principles to our Lyme study. So just as an overview, what was the gap that we were trying to address using these implementation science tools? And the gap was this urgent need for research to facilitate the uptake and sustainability of interventions among high-risk populations, which I've already described. The Caribbean and Caribbean descent populations are part of that high-risk group. So our objective was to design a hybrid 1 effectiveness implementation trial with the goal of reducing the incidence of diabetes among Caribbean descent individuals. And I'll describe hybrid 1 studies in a minute. To use stakeholder engagement and implementation research methods to design the intervention and implementation strategy, and to implement and evaluate the intervention using implementation science frameworks. So this is our Lyme study. So this is an evidence-based intervention to reduce the incidence of diabetes among high-risk patients who self-identify themselves as Caribbean descent, who have prediabetes, using a combination of lifestyle and metformin medication. So we take the highest risk patients. So we are targeting the 6 to 6.4%, and who are also overweight or obese. We expose them first to a series of lifestyle modification workshops. We give them 6 months. If they're unable to reduce their weight by that recommended 7%, or they're unable to bring their A1C down past that high risk 6 to 6.4%, we give them metformin medication, which is per the American Diabetes Association. So why did we decide to do a hybrid 1 trial? And what is a hybrid 1 trial? So in implementation science, as much as we are really focused on that T3 to T4 level, we recognize that in some cases, we don't have all the evidence, and we haven't fully proven effectiveness. And so we really need to fully do that first before we can focus completely on the implementation side of things. And so that's where the hybrid designs have come to fruition. And we have 3 hybrid designs, and each of them is just a spectrum of what you are placing most emphasis on between effectiveness and implementation. So hybrid 1 trial, your primary outcome is an effectiveness outcome. You're trying to prove effectiveness. You are powered to prove effectiveness. But you're also recognizing that it's important today for me to study implementation, because I have my eye on the next step, which is how am I going to scale this up? How am I going to adapt this to different settings? And I'm not going to be able to do that if I didn't study the process while I was studying effectiveness. Hybrid 2 is equally focused on effectiveness and implementation. They are co-primary outcomes. I've been told that when you're writing a grant, it's really hard to make the case for a hybrid 2, so I'll just put that out there. It is hard to show that you have the resources to be able to completely and fully study effectiveness as well as study implementation. But that is what technically a hybrid 2 is. And hybrid 3 basically says that I know that it's effective. Right? I have enough evidence out there to show that it's effective in different contexts. And I maybe will show some intermediate outcomes, but I really don't need to have a full power for a full 3-year study for diabetes prevention, for example. So my primary outcome is implementation, and you delve a lot of work and resources to a mixed methods approach to studying the implementation process. So we are doing a hybrid 1 because, 1, we didn't want to do the DPP. We wanted to really engage our stakeholders in using a proven, but not proven in our context, lifestyle intervention workshops that was not as resource intense. So we needed to prove that it was effective in reducing diabetes incidence. And we also wanted to combine it with metformin, which technically has not been shown yet, because again, there were separate arms in the DPP, not a combined arm. So what were the 3 key trials that informed our research design? And these are them. So one was the DPP I've already described. I'll tell you briefly about DCLIP. So DCLIP was actually a very similar metformin escalation trial that was done in India, that took patients, exposed them first to lifestyle. Their lifestyle was based on the DPP, and then gave them metformin if in 4 months they had an impaired glucose tolerance. So they only waited 4 months. And they showed that it also did result in a 32% reduction in diabetes incidence. I will say that 70% of their patients went on metformin, which is interesting. The HEAT trial is Help Educate to Eliminate Diabetes, which many of you are familiar with. This is a study that was led by Dr. Carol Horwitz here at Sinai. They used a community-based participatory research approach to actually design a diabetes prevention intervention. And I'll talk more about the workshop curriculum. But this is a very interesting workshop curriculum that showed sustained lifestyle, sustained weight loss at 12 months. So these are the 3 trials that we used to design our intervention. And as you can see, the difference between our line and each of these 3 trials is that, yes, we combine lifestyle and metformin, we tailor it now to Caribbean and Caribbean descent populations, and we integrate it into a healthcare setting. And I'll talk step by step to the reasons why the design included these features. So Lyme is being implemented in 5 and likely a 6th site now here in New York. So they are all clinical sites, the U.S. Virgin Islands, Puerto Rico, Barbados, here at Sinai, and then we're looking to recruit a site in the Bronx. The sample size is 750 participants, intervention and control, which gives us an 80% power to detect a 33% difference in the, again, diabetes incidence over 2.5 years. So as we had said, one of the limitations of all of the other translation studies have been that they've been 12 months or less. So they really can't show a reduction in diabetes incidence. What we've tried very hard is to design a study where we actually can look at incidence. So these are the specific sites that are implementing Lyme. The U.S. Virgin Islands, Barbados, and Trinidad are all Ministry of Health affiliated sites, and this will become important when we talk about our stakeholder group. In Puerto Rico, it is a family medicine clinic that's affiliated with the University of Puerto Rico in Carolina. Carolina is actually a relatively poor area of Puerto Rico. And then Sinai and then the Bronx. I'll just kind of mention here, because this question always comes up, which is what is your control arm? So in our island sites of the U.S. Virgin Islands, Barbados, Trinidad, and Puerto Rico, we are very fortunate to have an ECHORN cohort study. So one of the 3 pillars of ECHORN is capacity strengthening, implementation, and the ECHORN cohort study, which is a longitudinal study that was started in 2012, which follows community dwelling adults. And we are very fortunate that they just launched their wave 2, their second follow-up wave. And so it gives us the opportunity to align our intervention participants with the control participants being ECHO cohort study participants. This is nice because it's less work on our intervention sites because they only have to recruit an intervention arm. It's nice because we don't have to worry about contamination, which is always an issue when you're working in the same site. And we'll talk a little bit about how we frequency match by age and the BMI class. Our New York sites, though, we don't have the luxury of having a cohort study here in a similar way, although we've been brainstorming some other approaches that we could use. So for now, our approach is to use block randomization and have a delayed intervention for that. So this is a quick description of the whole study. So we screen for eligibility, and the eligibility criteria are here. If they are eligible, they come in and do a point-of-care hemoglobin A1C test. If their point-of-care test is between 6 and 6.4%, they are then officially in the intervention. They get a baseline survey, and these are the instruments we're looking at for clinical assessment and some blood work. And then they get exposed to intervention, which is a lifestyle intervention workshops, 6 workshops, 2.5 hours each. And then at 6 months, if they do not lose any weight, or their A1C does not come down below 6%, they get metformin medication. And then we follow them up regularly in 6 months intervals. So our primary outcome, again, is incidence, and these are our secondary outcomes. Eligibility criteria I'll go through briefly because this is usually another point with many questions. So age is 40 to 60. We're using a BMI cutoff of 23 here. No history of gestational diabetes or type 2, not on any blood sugar medication. They do have to be linked somehow to a provider, and they do need to have insurance. And not pregnant, and obviously an ability to attend the sessions. So the first question is why 6 months? Why did we not do a DCLIP did, do 4 months? Why did we decide to do the intervention for metformin at 6 months? And the reason is really here, that from the DPP, we clearly saw that the largest reduction in your A1C happened at 6 months. And after 6 months, it just went up. So if you're gonna be good, you're gonna be good at 6 months. If I check you after that, you're likely not to be good. So my best bet to actually show that you do not need metformin is if I check you at 6 months. And the same with the DCLIP study, 6 months. I don't have that slide here, but weight loss was the same thing. The largest reduction in weight happened at 6 months, and after that we went back up. Oh, this is the weight. So again, 6 months, and after that it was stagnant, and then just came back. So that's why we chose 6 months as our time for intervention. Why 40 to 60 years? This is partly constrained by our cohort study, which recruited adults starting at the age of 40. So if we really do want a frequency match based on age, we can't recruit a younger population. That is truly unfortunate. But we end at 60 because the American Diabetes Association recommendations is really not to use metformin in the older population. That was shown to be a group within the DPP that did not benefit from metformin. Why body mass, BMI, and waist circumference cutoffs? So we have a lot of data that's showing that BMI may not be the best anthropometric measure of obesity in minority groups, especially in Caribbean descent populations. And we start at a lower cutoff because Trinidad has a significant proportion of Asian individuals. Why insurance? So we've gone back and forth a lot about this. So sustainability. In order for us to kind of have this be an intervention that could be sustained, we need to be able to show that this is something that can happen within a clinic setting, that the clinic has a way of maintaining and sustaining, and that patients have a way of paying for their labs and paying for them. So as much as we've gone a little bit back and forth, it was felt to really be the best model in order to create sustainability and scale up in the future. Why A1C is 6 to 6.4%? I think I've honed this enough now that we have a lot of data to show that you're going to get the largest bang for your buck if you focus on that 6 to 6.4%, both in terms of clinical outcome as well as cost. And so I just want to kind of briefly describe how we went through really using our stakeholder group to design the implementation strategy for this trial in our Caribbean sites, as well as adaptive lifestyle modification workshop series. So who are our stakeholders? So we're very fortunate in ECHO to have a group of over 55 individuals that span think organizations and disciplines across the Caribbean. These 55 individuals are organized into working groups. Each is led by a chair and a fellow within or is part of the community of stakeholders and across our island sites. This group is led by 2 eminent individuals in the region, Dr. Laverne Baxter, the Professor Emeritus of the University of the Virgin Islands, and Professor Sir Trevor Hassel, who you saw before, leading the CARICOM delegation at the UN high-level meeting and directs the largest civil society organization in the Caribbean, the Healthy Caribbean Coalition. So I work very closely with Sharon Williams, who heads the implementation core. And there are two key ways that we engage these stakeholder groups: implementation strategy, and two was to adapt the lifestyle workshops. Starting first with our implementation strategy. In implementation science, we call it a science because there's this belief that rigor and methodology is critical to trying to describe how we design interventions, how we implement them, and how we describe them. And one of the tools that is used very frequently is a model that's called the RE-AIM model. And this was a model that was created in 1999, really to try to address the gap that we had in the description of interventions and try to describe why and how interventions were actually effective. And the model proposes that if you look at reach, effectiveness, adoption, implementation, and maintenance, you have a solid way of describing the key elements to intervention success. The definitions of these are here, but I think it's easier if I go through them in terms of describing them for our study. So for reach, we wanted to look at the percent of patients with prediabetes within these clinics who actually participated in the intervention. The engagement of men and how to prevent, which is always different in lifestyle modification studies. And how does reach change in the USVI and Puerto Rico, recently hit by the hurricanes? Effectiveness, how do we increase retention? How do we increase adherence? Adoption, how do we get more buy-in from providers, administrators, and the individuals themselves? How do we engage other health centers? For implementation, how do we capture the site-to-site differences that we're bound to see? And how do we address the challenges of implementation? And for maintenance, the ever-present question of sustainability. So we pose these questions to a series of stakeholders in a series of stakeholder meetings to try to refine our implementation strategy. So this is just a process framework where we start with screening and go all the way down to decreasing the incidence of diabetes. And with each of these steps, we kind of talk to stakeholders about steps. Let's think about RE-AIM. Let's think about how we can increase and improve each of those reach, effectiveness, adoption, implementation, and maintenance domains. So we screen for high-risk patients with prediabetes. Eligible patients with prediabetes are identified. We want them to attend the lifestyle workshops. We want them to adhere and sustain their lifestyle change. We want providers to prescribe metformin when it's necessary. And we want patients to take and adhere to their metformin when they're prescribed it. And then we get the decreased incidence of diabetes. So this is our process model. This is, at each one of these steps, there's going to be a behavior change that we need to influence, and that's going to improve our RE-AIM domains. So our stakeholders had a bunch of recommendations for each of these steps and how to improve for outreach. They really wanted us to make testimonial videos. And so we now have testimonial videos from Dr. Horowitz's HEED, and we've actually taken out and highlighted the men in those videos as a way of hopefully engaging more men. They've done radio and TV broadcasting in Barbados and Trinidad that started recruitment. For effectiveness, we'll talk a little bit about this when we talk about adaptation, but how do we get more buy-in from individuals to come to these lifestyle workshops? For adoption, how do we get administration buy-in to provide the time for trainings? How do we get peer support, use peer pressure to actually motivate people? And how do we disseminate into the community? For implementation, we've done a lot of work with capacity strengthening for each of our aligned sites. And for maintenance, again, how do we think about sustainability, which was a really big thing our stakeholders wanted us to focus on. We've now incorporated sustainability approaches within the workshops. So let's talk about the workshops. And let's talk specifically about, one, the evidence for the workshops, but also the process we use to adapt them. So like I said, the workshops that we're adapting are the HEED workshops. These stem from the Chronic Disease Self-Management Program. This is a curriculum that was developed in Stanford, developed initially as a peer-led initiative to focus on chronic disease. They were actually able to show that their chronic disease curriculum was cost-effective. It was based targeting people with multiple chronic conditions and who are on multiple medications. It's based on self-efficacy and self-management and teaching those principles using action plans at the end of each workshop. And you come back the next time and you get feedback on those workshops. And that cyclical process was really helpful. They then made a diabetes self-management curriculum, also shown to be cost-effective. And then he took this diabetes self-management curriculum and made it into a diabetes prevention curriculum and showed that it sustained weight loss at 12 months. So what we now wanted to do was to take those HEED workshops and adapt them to make them live Lyme, again, is our diabetes prevention study. We wanted to use a stakeholder engaged approach. So our first question to Sharon Williams, who heads the implementation work group, was who is not at the table? Who is not in this work group that we need to make sure is represented, and who do we need to bring in? And you see the list here, but most important is this group, which was the HEAD developers, the people who initially developed the HEAD curriculum, because they would be the ones who are most familiar with what were the core elements of HEAD. Don't touch this, don't change it, because that's going to change the whole effectiveness of the curriculum. So because they were so intimately involved in its development, they would ensure that we stuck to fidelity. So we had a series of stakeholder engagement meetings you see described here, where we first kind of looked at the nutritional content. That's the easiest thing to do, and make some minor adaptations for the examples that were given in the curriculum for each of our island sites. We then looked at the actual cultural content and how that needed to be changed. And then we had a session just to talk about the hurricanes in Puerto Rico and U.S. Virgin Islands and what changes were needed to really, at the end, make sure we had culturally appropriate, sensitive, and relevant workshops. So we grouped our adaptations into content and delivery. And I won't go through all of these for the interest of time, but really just to maybe just focus on framing, which is really interesting. So, billing things as a weight loss intervention is not apparently as effective in the Caribbean, where body image and body perception are a big deal. And many people are very content with how they look and do not want to lose weight. And so we changed some of the framing in the language in the initial part of HEAD to really build this as a healthy weight intervention, and that actually losing 5% of your weight will help you prevent diabetes, but really won't change the way you look as much. The other big framing was in the Puerto Rico and the U.S. Virgin Islands. Why is this important to me a year after hurricanes, where I'm still struggling with many, many other things? And our stakeholders really felt that this was important, that self-management today in Puerto Rico and being able to self-manage your health was ever more important. And so how do we explain that to individuals and participants? So we changed the language in the introduction for Puerto Rico and U.S. Virgin Islands. For workshop delivery, one of the big things they wanted was to have us allow family members to attend the workshops, even though they did not have prediabetes, with the notion that it was really a family activity, eating, physical activity. And so in consultation with the HEAD developers, we allowed them to bring a family member to the workshop as long as they committed to attending all 6 sessions. So at the end, we have our HEAD core components, which we have not touched. And then we've adapted them, made adaptations so it's culturally appropriate, culturally sensitive, and culturally relevant. So we've pilot tested this through a series through capacity strengthening, and as we're doing the trainings and piloting the workshops. And every time we get feedback from our participants, we propose changes, we go and adjudicate it with the people who developed HEAD initially to make sure the changes were still consistent, and then we re-implement it. So these are some photos from our capacity strengthening workshops in Trinidad, Barbados, and the U.S. Virgin Islands. I don't have one from Saria. And then this is actually the chronic disease self-management program being done in Trinidad, which was very well received. They had 90% of their patients attend all 6 workshops. So this is to say that we do have an evaluation plan for Lyme, where we'll be using the RE-AIM framework to evaluate it. And we'll also be using something called the Consolidated Framework for Implementation Research. This is a very useful tool within implementation science to help us better understand how context and contextual factors influence how effective an intervention is. So that we're going to be doing qualitative interviews in all of our 6 sites and trying to use the CFR to understand why one site might be more effective than another. What are the contextual factors in one site that might have influenced how effective it is as compared to other sites? So far, we've completed our trainings. Barbados, Trinidad, and the U.S. Virgin Islands have started recruitment. Barbados and Trinidad actually just completed their first round of workshops. We have a Lyme advisory board that meets regularly to address challenges and make adaptations as necessary. And here at Sinai, we're also in process. We are very, very fortunate to have the Sinai team come on board. Came on board actually very, very early on before this was really fully in fruition, and really a key partner because the HEAD curriculum was developed here. And again, I cannot overemphasize the importance when you're doing adaptation to work with the people who originally created the intervention, so that you really know what are the core components and what are not. So at Sinai, the IRB has approved. We're now in the process of looking at the electronic health record and trying to parse out who could potentially be eligible based on a data pool from the EHR. And then we're planning a two-step recruitment, where initially that list of individuals who could potentially be eligible are mailed out a letter informing them about the study and the fact that it's specific to Caribbean descent populations, and because they really need to self-identify as Caribbean descent. We'll be having phone calls, which Shayna Rigger will lead, in trying to contact participants to gauge whether or not they do self-identify as Caribbean descent. Bring them in for that A1C test if it has not been done in the last month, and then recruit those who are between 6 and 6.4%. So we'll probably be starting that actual recruitment process in the new year. I do want to say that this was a very interesting model that Sinai created, which is who runs the workshops. Whenever we talk to all of these sites, the one greatest point that is always a stickler is who runs the workshop. It's a huge time commitment. It's a huge time commitment to do the training. It's a huge time commitment to actually conduct the workshops. So that's the biggest piece of sustainability that we're having trouble with. And so Sinai had the brilliant idea of, well, we have tons of MPH students that are not going anywhere. They're always here. And they always need a practicum. And wouldn't this be a perfect practicum for them? They're actually learning how to do diabetes prevention. They're learning all these things about interventions in the real world. And so that's the model that Sinai has, which I think is a brilliant way to have a sustainable model for diabetes prevention. Just a few limitations. Use of A1C. There's a lot of issue with the A1C in minority populations and what it means. And on average, if you take a fasting glucose level, a minority individual will have a higher A1C for that fasting glucose. The pushback to that is, well, maybe that's what we need to do. Maybe we do need to target more minority populations, even if it means we're overkilling, right? We have, and if the solution is bringing more into our pool than might actually need it, then maybe that's what we need to do. The caveat is that we may not then see that nice drop-off at the 6 to 6.4% range. We won't know unless we try. That data's not out there. Use of point-of-care testing. Huge deal. The reason we're doing it is that it's fast, it's quick, and we can actually supply it at a very low cost. A lot of these island sites are low and middle income sites that do not have reliable A1C testing by serum. And so that was really the reason that was put in. But the diagnosis of diabetes, if you have an A1C that's greater than 6.5 or above, you are sent to do a confirmatory test by the choice that the provider wants. Different control groups for the New York sites, that's where our biostatisticians will come in and hopefully create an analytic way of addressing that. Requiring insurance, I've touched upon previously, and excluding younger populations, I think younger populations dear to my heart, so I do hope that we'll have future studies to be able to look at younger groups. So in summary, working in the Caribbean is important for the health equity agenda. There are many gaps in our knowledge for how to best do diabetes prevention in minority groups. Using implementation science and stakeholder engagement really allow us to design and evaluate interventions for sustainability and scale up. And really, we hope that Lyme can inform effective and sustainable efforts in the future, as well as perhaps even inform future cardiovascular risk reduction efforts in minority groups. Thank you.
Give you time for maybe one or two questions, and then if there are more, you can come up with them after.
I know you do a lot of nutrition counseling. How do you promote exercise?
So the curriculum, and actually Shayna just did the training, so she might know more. So it's six workshops, and each workshop starts off with a feedback session on your action plan the day before. My understanding from what they say for exercise is it's a minimum amount of exercise per day that they recommend. Shayna, do you remember from the curriculum what they specifically say about physical activity recommendations? I don't mean to put you on the spot.
No, it's fine. There are daily and weekly recommendations, but it's predominantly based around what each participant thinks they can accomplish each week. So it's less asking them to do a minimum of exercise, but more informing them of what a healthy minimum might be and asking what they feel capable of doing and setting a weekly goal to reach that minimum.
But they do give them the daily and weekly recommendation.
How can we refer our patient? I know you guys are looking to identify them, but you were just saying that it may be difficult from the EPIC data to identify Caribbean background patients. Can we, as providers, refer you patients?
Yeah. then by referring them, we'll send them a letter, reach out, and we'll determine whether or not they meet for review criteria on our end. So just if you have patients that would meet the health criteria, then we can.
Is it particular violence in the group here?
No, as long as they self-identify as Caribbean descent.
And you can do that by emailing Gina or myself.
And they have to come into a 6-week period of how many hours or 1 hour?
It's 2.5 hours.
So just to tell the patients.
Yeah.
That
Yeah.
it'd be helpful, right? Because we're not going to work out.
Yeah, that'd be great.
How do patients get labeled? I always worry about with the changes in health insurance and things like that, sort of like labeling people. So do they get labeled as like pre-diabetes and that's a pre-existing health condition for the future? Or how does that happen? I know it doesn't affect the study, but
Yeah. So are you concerned by labeling them as prediabetes based on a point of care?
yes.
Yeah. So actually, I don't know. Does it go in their chart?
Well,
What happens
we
with the
would
study?
need to do that to like prescribe the metformin. You have to have a diagnosis,
yes.
and so you have
Okay.
to. And what's
I see.
interesting for us is as soon as you put something like that on, then all the other measures pop up that you're supposed to be doing as well. So it's always confusing if
Yeah.
someone has pre-diabetes or diabetes because you can't always parse it out.
Yeah. So can I ask you, how do you do it now? Do you get a serum A1C every time on a patient who's overweight or obese?
It depends on if we don't have POCTs, then we'll do a serum A1C.
But you do sometimes do a POCT.
Yeah, depends on
Because that's what we do in clinic. We
Right.
sometimes do diagnose people with prediabetes based on a point of care
Right.
A1C. Because clinically, if it's a 6.8 on a point of care, the patient's got prediabetes.
Yeah.
And everything else kind of fits. So I know in our clinic setting, we wouldn't be too worried about it. Oh, sorry, not 6.8, 5.8, yes. But in our clinical setting, we wouldn't be too worried about a point of care A1C using that to put in the chart prediabetes. But if that is a concern here, I think we can talk about ways of going around it.
Does point of care typically over or under? Is it predictable how unreliable it is, or?
Here it's more reliable the lower level. So like that's what Dr. Cameron did when we were doing A1Cs and comparing. He said that it was less reliable at the high, like we were sometimes missing people at the higher level. So it's more reliable the lower the A1C. Once
Like
you get
lower, like as in like less than 8,
Yeah.
or lower as in
if you
greater?
get to like 9, they're probably really 10.
Got it.
So that's what our experience is. Our best range is that 6 to 8. We're actually pretty good. Less than 6, we're not so good. And greater than 9 or so.
Thanks, you guys.
Thank you all.